Good evening and welcome to this program on colon cancers from the AIG Hospitals. I am Nageshwar Reddy. I am a gastroenterologist at the AIG Hospitals. This month is the colon cancer month, awareness of colon cancer. And what we are doing at AIG is to increase both awareness among the public and the science part awareness among the doctors on colon cancers. We are having a series of webinars, the first of which is going to be today, followed by one daily for the next 4 days. The first series of webinars are going to be on the basic science aspects of colon cancer and imaging the colon cancer and what is new in this area. We'll start first with Dr. Ravikant, who's our Chief of Cancer Genetics at the AIG Hospitals. She's going to talk to you on pathways of colorectal cancer in India, how they differ from the Western countries. Ravikant.
Thank you, sir. Based on the data that we generated in-house and compared to the literature that is available, let me address in the next 15 slides whether the pathophysiological pathways of colorectal cancer in India are different from the West. Now, a quick look at the published literature suggests that majority of the colorectal cancers are sporadic cases, while 10 to 30% are cases with familial risk, and less than 3% form the Lynch syndrome or the hereditary non-polyposis colorectal cancer, and the familial adenomatous polyposis and the hamartomatous polyposis syndromes are less than 1%. Now, literature suggests that there are three major pathways for the pathogenesis of colorectal cancer. They are microsatellite instability, chromosomal instability, and CpG island methylator phenotype. Let's now look at microsatellite instability. Microsatellites are simple sequence repeats or short tandem repeats of 1 to 6 nucleotides in the human genome. For example, A, T, Ca or the CAG repeats are repeated at multiple number of times in the human genome, although at a fixed number. Now, microsatellite instability is if there is a mutation in the DNA repair genes, predominantly the mu-tel homolog or the mu-tes homolog. These repeat sequences, they tend to become longer or shorter, and this change is something called as a microsatellite instability. Now, this happens because of a mechanism called as replication slippage, where DNA polymerase, when it encounters these repeat sequences while replication, it tends to increase the number of repeats and forms a loop of mismatched DNA from slippage. Now, in an individual with the DNA mismatch repair intact system, that is, there is no mutation in the mu-L or the mu-tes homolog genes, the repeats are restored back to normal. However, if there is a mutation in these genes, the repeats are carried forward. This is something called as a microsatellite instability. Now, we did a study at AIG where we looked at the microsatellite instability in all young colorectal cancer patients below 40 years of age, and we have seen that the instability is seen in almost 50% of the colorectal cancer patients. MSI high was seen in around 13% of the patients, and MSI low was seen in around 35% of the patients. Usually it's a mutation in the mu-tel homolog and mu-tes homolog genes. However, we have seen that predominantly there was promoter hypermethylation in the promoter sequences of these particular genes, which was seen in almost around 75% of the MSI high and MSI low individuals. Now, the difference is majority of the MSI positive tumors in the Indian ethnicity were in the left colon and the rectum, unlike in the West, which is in the right colon. Also, the MSI in the left colon was associated with advanced stage of the disease. This was probably the first study where we identified that probably the tumors in the Indian ethnicity are different from the West. Now, the second pathway is a chromosomal instability pathway. A lot is known about chromosomal instability pathway, which usually passes through the adenoma carcinoma sequence in the Western population. The driver variants as well as the sequence of events are very well mapped in the Western population, where a normal epithelium via the intermediary and the late adenoma progress to cancer, and APC is the predominant driver mutation apart from KRAS and BRAF genes, and later on the TP53 and the TGF beta variants that are included that transform from normal epithelium to the cancer, and of course add the expression level, it is the Wnt signaling that is predominantly dysregulated in the Western colorectal cancer. Now, if you look at the canonical Wnt pathway, whenever the Wnt binds to the frizzled receptors, the destruction complex is not together and it is unable to destroy the beta-catenin, which moves into the nucleus and turns on all the cell proliferation genes, causing the transformation of a normal epithelium into an adenoma. However, when there is no signal, usually the destruction complex phosphorylates the beta-catenin and degrades the beta-catenin, therefore it doesn't move into the nucleus and the target genes are not switched on. Now, the driver variant that I was speaking about in the APC gene usually does not degrade because of the variant in the APC gene does not degrade the beta-catenin, and beta-catenin moves into the nucleus and the cell proliferation occurs. Now, with this background, we initiated this study to look at majorly how much percentage of tumors of the Indian ethnicity actually follow the adenoma carcinoma sequence, and if just in case it is a minority in number, we wanted to identify the pathway that is predominantly there in the Indian colorectal cancer. So we have totally screened upward of 1 lakh patient records, including 75,000 odd colonoscopy data and 25,000 odd surgical data. And from the surgical data between 2015 and 2018, we have collected a total of 259 tissues that we utilized to look at the variants at the DNA level, expression at the RNA level. We also did a global gene expression and of course the immunohistochemistry at the protein level, and the colonoscopy data was predominantly used to look at the polyps that are prevalent in the Indian ethnicity. If we look at the polyp data, a total of 68,258 colonoscopies were included to mine for the polyp data, of which around 38% had an abnormal finding on the colonoscopy. Of these, of the 26,322 abnormal colonoscopies, a total of 4,355 polyps were identified, which puts it at 16.54%. Most of the polyps, anyway, colonic polyps and all the different types of polyps were identified in the patients. We also screened the tumors, the colorectal tumors, for mutations in APC, beta-catenin, KRAS, NRAS and BRAF, typical that are the drivers in the Western population. We identified deletions, insertions and missense mutations in these tumors. However, the variants were only identified in 18.27% of the tumors when we screened for APC, beta-catenin, KRAS and NRAS, which are typical drivers in the Western population, but in a minority in the Indian population. If you look at the variant burden, it is only 12.5% in the APC and 5.77% in the beta-catenin, which is almost around 70% in the Western population and the driver variant in the Western population. Now, if you look at the typical canonical Wnt signaling, usually at the expression level, APC is downregulated, beta-catenin is upregulated, and the MYC, which is the proliferative gene, is upregulated in the colorectal tumors. However, all three dysregulated genes were found in only, again, 18.33%, which is similar to the polyp data and the mutation data. And interestingly, only MYC was upregulated in 48.33%, suggesting that there's some other gene apart from beta-catenin that is actually upregulating the MYC, and that is where we have done a microarray. That is, we looked at the global gene expression. This is a very busy slide. I'll just simplify it for you. The four cardinals of the cancer, that is the proliferation, the apoptosis, invading apoptosis, the sustained angiogenesis and the metastasis, all the genes that contribute towards this particular thing are enriched in this pathway, and all the identified pathways till date are present in this particular slide. Now, typically the Wnt signaling pathway should be enriched when data from the microarray from the Indian tumors were actually given to this particular pathway. However, we see that it is not the Wnt dysregulation that is seen, it is predominantly the gene called as junction plakoglobin or the gamma-catenin that is actually upregulated in these tumors. Now, this was again validated by doing a transcriptome sequencing on the next generation sequencer, where we have sequenced the entire mRNA on the NGS platform, and again we could replicate that it is the JUP that is, or the gamma catenin that is upregulated in these tumors, and to add to that, the concomitant expression of MYC along with gamma catenin was also seen in these particular tumors. Now, we have looked at the gamma catenin and MYC dysregulation in upward of 100 tumors of Indian ethnicity, and we see that there was a very strong correlation, that is, wherever JUP was upregulated, the MYC also was upregulated, and it comprised of almost around 50% of the tumors. Now, all this data was also looked at the immunohistochemistry level, that is at the protein level, where there was weak positive gamma catenin upregulation or strong positive upregulation, and the same tissues were also stained for beta catenin, and it was nuclear negative, suggesting that it is probably the gamma catenin that is upregulating the MYC gene and is probably involved in the tumorigenesis in the Indian ethnicity. Taken together, if we look at the percentage of polyps in the Indian ethnicity, it's around 16%. The total variant burden in the APC and beta catenin put together again is around 18%, and the width dysregulation at the mRNA level is around 18%. All point to the fact that probably it's only somewhere between 15 to 20% of the traditional adenoma carcinoma sequence is seen in the Indian ethnicity, and it is not the Wnt dysregulation that is seen, it is the gamma catenin that is actually operating the MYC involved in proliferation, and probably this is the driver in approximately around 50% of the tumors. Now, there is a very strong correlation of gamma catenin upregulating MYC in the clinical specimens that suggests probably this is the driver. We acknowledge the funding, internal funding as well as the external funding, and on behalf of all the investigators who are involved in the study, I thank the audience for a patient listening.
Thank you, Ravikant, for that nice summary showing very clearly that there is a difference in the pathways of how colon cancer comes in Western population versus what is happening in India. I think this is very important data, and for the first time it has been shown that we have different regulatory pathways, and it becomes very important that we screen our patients in a different way. Thank you for that information.
Thank you, sir.
We next go on to our next talk, which is going to be on prognostic and predictive markers in colorectal cancer, and this is going to be by Dr. Anuradha Shekharan from Head of Department of Pathology at the AIG Hospitals. I think this again is a very important topic, because we'd like to know what happens in terms of how you can predict these markers in patients' colon cancer. Anuradha?
Yeah. Good afternoon. Thank you, sir. Today I'll be talking about the prognostic markers and few predictive markers which we can see in the histology specimens which are submitted. As we know that the pathological tumor staging is probably the strongest predictor of survival, but there are various histological features like the tumor type, the tumor grade, vascular invasion, perineural invasion, and others which are important markers which indicate aggressive biological behavior. So, a precise and standardized pathology report is very, very vital for optimal prognostic assessment and further therapeutic decisions. So, when we get a specimen for evaluation, particularly if you take the lower APR specimen, the most important role that the pathologist has to is to identify the bare area or the non-peritonealized surfaces on both the anterior and posterior aspect, and this is very important because this is required for evaluation of the circumferential radial margin, which plays a very important role in assessing the further prognosis of the patient. So, if you see this bare area is absent, the peritoneal covering is not seen in the distal 1/3 of the pancreas, and in the middle 1/3 peritoneum is only seen on the anterior surface, and in the proximal 1/3 it is found only on the anterior and lateral surfaces. So, when we receive this specimen, it is important to identify the mesorectum, and this is a very optimally excised specimen, and the role of the pathologist is to ink the bare areas and then further take circumferential rings of the tumor so that we get to evaluate the circumferential margin. So, when we are assessing the specimen, it's also important that we look for any areas of perforation and take optimal sections from the tumors as well as multiple lymph nodes. The surgical margin evaluation is not only the proximal and distal, but it's the circumferential radial margin, which, as I said, is the most important predictor for local recurrence. A 12-fold increase in recurrence is seen in many studies wherever you have a positive circumferential radial margin, and it also gives a clue about the distal recurrence and overall survival rate. And a positive circumferential margin determines further adjuvant therapy, particularly whether the patient requires further radiotherapy. In his gross evaluation and microscopic evaluation of colorectal cancers, we need to look further into the following prognostic markers, which I will cover one by one. The first important thing is to type what is the histological variant. So usually you have your adenocarcinomas NOS, and you have other variants like the mucinous adenocarcinomas, the signet ring cell adenocarcinoma, serrated adenocarcinomas, basaloid or cloacogenic carcinomas, medullary carcinoma, cribriform carcinoma, neuroendocrine carcinomas, micropapillary carcinomas. Now, what is the prognostic significance of identifying these histological subtypes? Variants like adenosquamous, neuroendocrine carcinomas, squamous cell, signet ring cell, undifferentiated and mucinous carcinomas by default are high-grade neoplasms, so they are at risk for aggressive behavior. Medullary carcinomas, on the other hand, though they appear poorly differentiated, behave as low-grade tumors. Grading of the tumors is done into 4 grades based on the percentage of the gland formation from well-differentiated tumors to undifferentiated tumors where you have no gland formation. This grading is, however, not applicable for poorly differentiated neuroendocrine carcinomas. So, the well-differentiated will have more than 95% glands, moderately differentiated will have 50 to 95% glands, poorly differentiated will have less than 25% glands, and undifferentiated is where you have no attempt of gland formation. The 2017 Ajcc Tnm staging, or the 8th edition, is the currently used staging for the colorectal carcinomas, and there have been some changes or in the editions which have come, and the most important updates are the recognition of M1C, that is the peritoneal metastasis, which is a very important indicator of poor prognosis. There was a lot of difference in defining the regional lymph node metastasis and introducing a definition of the so-called tumor deposit, where a circumscribed tumor deposit is now given the category of N1C, which is irrespective of the T stage. Lymphatic and vascular invasions have been defined separately, and additional indicators for guiding clinical practice are MSI as well as the KRAS, NRAS and BRAF mutations, which my earlier speaker has already said. The most important step when we are trying to stage the tumor is to define whether it is T3 or T4. Now, if you see in the first picture, a T4 is one where the tumor glands reach up to the inked serosal surface. It is very easy to identify when the tumor glands are exactly on the inked surface, but when there are circumstances when the tumor glands fall short of reaching the inked surface margin. So, when the distance of the tumor to the inked margin is less than 1 mm, it should be upgraded as T4A. There are certain times when there is no inked margin and you have these crevices, and these are the serosal crevices. So, the pathologist has to carefully look for the mesothelial lining, and any tumor which reaches these serosal crevices is also T4A. There are challenging cases when we are not able to identify whether it's a deep T3 or a T4A, and this is when there's a lot of fibroinflammatory reaction and peritumoral abscess. In such cases, it is advisable that we go further for either an elastin stain or employ an immunohistochemistry like cytokeratin, wherein you can identify the tumor cells and see whether they are reaching the inked margins. Also, another role is to use IHC like CK7. Cytokeratin 7 will highlight the mesothelial cells, as you can see here, and it will identify the tumor cells which are reaching up to the margins, and this also becomes T4A. Now, what are tumor deposits? Tumor deposits are a tumor either in the pericolic or perirectal fat or in the adjacent mesentery like the mesocolic or the rectal fat within the lymphatic drainage area of the primary tumor, but without any identifiable lymph nodal tissue or vascular structure. In case any vessel wall or its remnant is identified, it should be classified as vascular invasion and not as a tumor deposit. Now, why is it important that we identify these tumor deposits? Because they have been recognized as an adverse prognostic factor, and the latest edition of the AJCC suggests that it should be classified as N1C, and adjuvant therapy is usually warranted in these cases. So, for example, if you see here, the first picture shows a classic metastatic lymph node with tumor deposits, whereas the second and third pictures show a circumscribed tumor deposit but without any identifiable lymph nodal structures. Now, these are what should be classified as tumor deposits or the N1C. And if you see the last picture, it is very difficult to make out whether this is a fibrosed lymph node or a hyaline thrombi or a vascular thrombi, or whether it's a circumscribed tumor deposit. In such cases, you have to employ IHC like PanCK to see if there are any residual tumor cells and then label it as tumor budding. Lymphovascular invasion and perineural invasion, these are very important adverse prognostic markers. Small vessel invasion should be reported separately from large vessel invasion, and small vessel invasion is usually found to be associated with lymph nodal metastasis. Venous and perineural invasion can be either intramural and extramural, and extramural is a very important factor, prognostic factor, because it's an important risk factor or an indicator that there is possibility of liver metastasis. Now, for example, if there is a presence of a naked artery in the pericolic fat, then this is a clue that we are looking at extramural venous invasion. And if there is any extravenous extension like this circumscribed tumor deposit, this should be taken as a venous deposit rather than a tumor budding. Then tumor budding. These are presence of single cells or small clusters of cells less than 5 cells at the advancing front of the tumor, and high tumor budding in adenocarcinomas, particularly those arising in polyps, indicates a significant risk factor for nodal involvement, and this is also very common among MSI proficient tumors and also in stage 2 patients where it is indicates adverse prognosis, so should be considered as a high risk factor for further chemotherapy. The tumor budding should only be done on HND sections, and in cases where you have obscuring factors like marked inflammation or necrosis, employ IHC for keratin to identify these tumor cells and count the high cells per 20 high power field, and then give a 3-tier score based on the number of buds, where a low score is when you have 0 to 4 buds, intermediate is 5 to 9, and high is when you have 10 or more buds. This is a tumor bud where you have isolated tumor cells at the advancing front of the tumor, and this should not be confused for the poorly differentiated tumor cells which can be seen in association with the tumor buds. The host immune response to tumor is of 2 types. This is tumor infiltrating lymphocytes or a Crohn's like lymphoid reaction. And why is it important that you identify these? Because they have a very good prognosis and a significantly improved 10-year survival rate. Now, these are the small lymphocytes along with your tumor cells, and this is the Crohn's like lymphoid aggregates which are seen at the advancing front of the tumor, and these have good prognosis. Also, tumors which are associated with marked desmoplastic stroma are associated with poor prognosis and increased risk of liver mets, and these are also associated with MSI high type of phenotype. Now, in the current era of interventional management by the medical gastroenterologists, and there is optimal treatment of resection of the tumors by endoscopic level. This calls for a new era of interdisciplinary relation between the pathologists and medical gastroenterologists, and this is mostly employed for early stage cancers, and the aim is for en bloc and R0 resection. So, an optimal pathological evaluation is very important so as to give a correct diagnosis and to avoid further major surgery and for better stratification and guidance. In the polyps, the basic idea is to resect the polyps which are limited only to submucosal invasion. So, the intramucosal cancers are those which are limited to the muscularis mucosa, and the invasive cancers are those which go into the submucosa. So, the most important step is to identify this submucosal invasion, and the critical step is to identify the SM1, that is the early submucosal invasion when compared to SM2 and SM3. And there are various prognostic factors which you, as a pathologist is very important that you report in your EMR ESD specimens, which can give a further clue whether the management is complete or the patient needs to go for further surgery. And the histological parameters which are of prime importance in identifying these are the differentiation of the tumor, a poorly differentiated carcinoma, or a tumor which is less than 1 mm from the resection margin, presence of lymphatic and venous vessel involvement, and submucosal involvement of more than 1000 microns indicate that the patient is at high risk for lymph nodal metastasis, and presence of any one of these pathological prognostic factors indicates that the patient should be further subjected to surgery. So when we get a specimen and when we are able to identify the muscularis mucosa very clearly, we evaluate the depth of submucosal invasion from the muscularis mucosa to below. When the muscularis mucosa is not easily identifiable, it is better that we try to draw an imaginary line from the adjacent viable muscularis mucosa and then calculate the depth of submucosal invasion. If that is also not clear, we can employ a Desmin IHC marker which will identify the adjacent residual muscularis mucosa and the depth of invasion is identified. But there are certain cases when the whole tumor will be ulcerated and eroded and you cannot make out any identifiable muscularis mucosa. Then the depth of the invasion should be from the highest point of the viable tumor to the vertical point and give the maximum depth of submucosal invasion. So for example, if you see here, this is an area where you have a clearly defined muscularis mucosa in picture B, and so you have to measure the depth of the tumor from the viable muscularis mucosa till the maximum depth in the submucosa. As in this case, it was 500 microns, and here if you see, you have a very good SM2 and SM3, a very good submucosa, and your deeper margins are free. So this makes it an optimal surgical resection wherein the tumor is completely resected. But there are certain cases, as we have already said, when you cannot identify the submucosa and even Desmin is not able to identify your residual, then you measure the depth from the highest point of the tumor to the lowest point where the tumor is infiltrating. So here if you see, the depth is around 3500 microns, which makes it a poor prognostic factor and need to go for further surgery. Now there sometimes you get only a shallow submucosal dissection as in the first picture, wherein still you can identify the submucosal invasion, but in shallow submucosal dissection it is not possible to identify lymphatic and vascular invasion. Compare it with the second picture where you have a very good submucosal tissue included in your specimen, which is said to be an optimal resection wherein it is easy to calculate and identify the other prognostic markers. And as I already said, wherever in doubt, employ an IHC stain like Desmin, which will identify your residual muscularis mucosa and then measure the depth. Now, treatment effect. Neoadjuvant chemoradiation is now being used for most of the colorectal cancers, and this is required for significant tumor response and downstaging of the tumor. And minimal residual disease has shown to have a better prognosis than gross residual disease. And when we get the specimens post-treatment, we have to employ the modified Ryan scheme for assessing the tumor response. And the modified Ryan scheme is on a scale of 0 to 3, where 0 is no viable cells, that you have complete response. 1, when you have only single cells or rare group of cells, which means a near complete response, and you have more of desmoplasia in such cases. And score 2 is when you have more than single cells, and score 4 is where there is hardly any tumor regression. So tumor regression should be used only in the primary tumor and not in the lymph nodal metastasis. And when you have acellular pools of mucin, do not assign any PT stage or do not count it as any positive lymph node. Extent of these changes in the primary tumor or the metastatic deposits is predictive of prognosis and with an improved disease-free survival. So this picture shows a complete response, whereas here you have scattered viable tumor cells, which makes it a partial response or grade 1. And grade 2 is easily identifiable tumor response, and grade 3 is there is no response. And this is another case where I would like to show that you have abundant mucin pools beyond your viable tumor cells. So even if these abundant mucin pools are reaching up to your inked margin, this should not be considered as a positive margin. So here your circumferential margin should still be considered as negative, and this will only should be considered as PT2. So also if you have a lymph node with some mucin but no viable tumor cells, it should be considered as a negative lymph node. MSI is one which is now being advocated in the 8th edition of AJCC for further prognostication of these patients. What is microsatellites? They are stretches of DNA sequences where a single nucleotide or units of 2 or 3 nucleotides are repeated in the genome. And MSI is a marker of dysfunctional mismatch repair proteins within a tumor. Basically, you have 4 main DNA MMR proteins, the MLH1, PMS2, MSH2 and MSH6, which constitute the MMR protein complex. Loss of expression of these proteins will occur either by promoter hypermethylation, which is very common in your sporadic or colorectal cancers, and if it occurs by germline mutations, it indicates hereditary or your Lynch syndrome or the non-polyposis colonic cancer syndromes. Testing for MSI can be done by IHC or PCR. So in IHC, you can have 6 different patterns of representation, wherein either you have positivity for all the 4 markers, which indicates that there is no defect, or you can have individual loss of either one of these proteins, which further indicates either they are sporadic or germline, and total absence of all these is a null pattern, which is very rare. Tumors which display loss of MMR proteins are called MMR deficiency or MSI-H, and those with intact MMR proteins are called MSS stable or MSI low. Now, what is the algorithm for Lynch syndrome screening? Once you do IHC and you have a normal IHC, then it's not a Lynch syndrome. Once you do IHC and you have concurrent MLH1 and PMS2 loss, you should further go for BRAF or MLH1 methylation. And if it is positive, it is not Lynch syndrome. And if it is negative, it indicates a germline mutational analysis for Lynch syndrome. Now, what is the need for doing this MSI status? So, whenever you detect MSI, it gives a further information whether the patient needs further adjuvant chemotherapy, whether he can be put on any of these clinical trials, or he can be considered for capecitabine or 5-fluorouracil therapy or the FOLFOX therapy. Also, the PDL1 is another molecule which has been upregulated in many cancers and also in colon cancers, and the PDL1 expression is closely related to a very late TNM stage or a lymph nodal metastasis and poor prognosis, and this is a very important biological marker for assessing invasion and metastasis. And many studies have shown that metastatic colorectal cancers with MSI-H will respond very favorably to immune checkpoint inhibitors, and these tumors tend to have high expression of checkpoint proteins which interfere with the body's anti-tumor T cell response. So various trials using various PD-L1 inhibitors like pembrolizumab, nivolumab have been used, and these have shown that if the patient is MSI-H, the response to these immunotherapy is very good, and the response rate is as high as 57% when compared to your MSS stable, where the response is only 0% to 5%. To conclude, evaluation of response to medical therapy in colorectal cancers is based on clinical evaluation, post-treatment imaging, prognostic histological assessment with a panel of biological markers for precision targeted therapy for optimal patient care. Thank you.
Thank you, Dr. Ananda, for that very extensive talk on how we can prognosticate malignancies, especially colorectal malignancies. It becomes very important in the era of, I think, endoscopic surgery, where, for example, the depth of the lesion, the pathological assessment is very important, and you have clearly emphasized on this. Next, we go on to another area which is again very important. This is imaging in colorectal cancer, and I think MRI imaging has made a huge difference in assessment of these cancers. And to talk to us on this is Dr. Tarini from the Department of Radiology of AIG. Dr. Tarini passed out from CMC Vellore and has extensive experience in GI radiology of over 15 years, and she'll talk to us on importance of MRI in rectal cancers. Dr. Tarini.
Thank you, sir. Good evening. So over the next 15 minutes, I'll run you through the importance of MRI or the role of MRI in rectal cancers. So it's broadly divided into local staging and setting a TNM stage for the cancer, and to determine if there are any poor prognostic factors like extramural vascular invasion, or if the tumor looks to be mucinous or signet ring cell type, and to determine if it is possible to resect the tumor right away, or if there is any need for neoadjuvant treatment. That is determined based on involvement of mesorectal fascia, or in other words, circumferential resection margin. And if there is any disease extending beyond the CRM, which will make the surgery not primarily possible and will need neoadjuvant treatment. And also to determine the type of surgery or extent of surgery, and to reassess the tumor after neoadjuvant treatment, and to ascertain a MR tumor regression grade. And a small subset of patients where total neoadjuvant therapy can be given can be predicted by MRI. So to quickly run through the T staging according to the AJCC 8th edition. So T1 tumor is when submucosa is involved, T2 is when muscularis propria is involved, T3 is when mesorectal tissue of fat beyond the muscularis propria is involved, T4 is when adjacent visceral organs or peritoneum are directly infiltrated by the tumor. So this is how an endorectal ultrasound picture would look, where there are multiple hypoechoic and hyperechoic concentric bands. So as we can see, the spatial resolution is very good, and so between the T1 and T2 tumors, there's excellent resolution on endorectal ultrasound. However, this is very difficult to make on MRI pelvis. So between T1 and T2 differentiation is difficult on MRI pelvis, and endorectal ultrasound and MRI pelvis are complementary. T2 and beyond tumors, MRI pelvis is mandatory for local staging prior to treatment initiation. Pet CT's role is in metastatic disease, and it is complementary to MRI in nodal staging. So when we do the MRI, it has to be done in a very tailored protocol, where high resolution T2 weighted images in 3 planes, 3 orthogonal planes with respect to the tumor must be obtained, and diffusion weighted imaging plays a very important role. I'll take you through that in a few minutes. So we don't administer or distend the lumen of rectum with endorectal gel. The reason is, when you distend the lumen, you tend to flatten out the tumor, you tend to flatten out the mesorectal fat around it. So the exact CRM measurement or exact extramural spread measurement will be compromised. And we don't have to give any antispasmodic agents. No prior bowel preparation is usually required unless the bowel is extremely fecal loaded, in which case we'd like for the patient to pass stools prior to the scan. And gadolinium enhanced or post contrast MRI has not shown to improve diagnostic accuracy in the local staging of rectal cancer. Its role in post treatment MRI assessment is debatable. So normally on a T2 weighted MRI, you see these layers. The arrows are pointing to the T2 hypo-intense muscularis propria. So you have a very clearly defined muscularis layer on T2 weighted MRI. So the mucosa and submucosa that is within the muscularis propria can be of variable thickness and variable hyperintensity. And so when tumor is directly involving or interrupting this T2 hypo-intense layer, we know it is definitely T2 disease. And if it is going past the hypo-intense layer, it is T3. And so the hyperintense fat that is seen all around the T2 hypointense area is the mesorectal fat or mesorectal compartment. And the thin T2 hypointense circular layer that is seen all around the mesorectal fat is the mesorectal fascia. So in addition, when you see a tumor, we determine if it is in the lower third of rectum, middle third or upper third. There are different ways to categorize it. The most important way to convey the message is actually giving the true distance between lower extent of tumor and anorectal junction, because anorectal junction is considered more stable checkpoint than anal verge on MRI. And we also make a comment on the morphology of tumor, whether it is polypoidal, circumferential or hemicircumferential. The signal intensity of the tumor can give us some clues. Majority of rectal tumors are intermediate signal intensity when compared to the muscular layers or muscle. So similar to that of muscle. But when they are hyperintense on T2 weighted imaging, that indicates that they could be mucinous tumors or signet ring cell tumors, which indicate a very poor prognosis. Now in this case, we see a lower third of rectal tumor. In the axial image, you can see that the tumor is mostly in the posterior half, but we are not sure. It is touching the muscularis layer, but we are not sure if it is actually infiltrating the muscularis. So it could be either T1 or T2. And so EUS in this case will have a complementary role in determining T1 versus T2 staging. This is another tumor where there is very obvious extramural involvement of the tumor, and it's going all the way up to the mesorectal fascia. But it's not enough to say it is T3, because T3 is a very, very wide category, and within T3, the early T3s have much different prognosis compared to late T3s. Hence, T3 is further subdivided into 4 categories depending on how much radially tumor is extending beyond the muscularis. So that is less than 1 mm is T3A, 1 to 5 mm is T3B, 5 to 15 millimeters of radial spread is T3C, beyond 15 millimeters is T3D. So we'll go through examples of each. The first image is where there is a very hyperintense tumor. You see that the T2 hypointers muscularis is completely interrupted there, and tumor is just about going into the mesorectal fat. So the tumor signal here is almost similar to that of fat. This is a mucinous tumor. And so this is a T3A with minimal extension beyond the muscularis layer. Second image is where there is a few millimeters radial extension. So the red line there indicates radially how you're supposed to measure the extramural spread. So radially in clock position manner from the expected location of muscularis propria. So when it's between 1 to 15 millimeters, 1 to 5 millimeters, it is T3B. This first image in this slide is when the extramural spread is beyond 5 millimeters and less than 15 millimeters, and so this is a T3C tumor. Now fourth image is where it's a bit challenging to ascertain the stage. Why? Because we see that there is a T2 intermediate signal intensity tumor, and there is also fat stranding in the adjacent mesorectum. But we are not sure if the tumor signal is actually going into the mesorectal fat, or is it just inflammation or desmoplastic reaction caused by the tumor. So in such cases, it's okay to ascertain T2/early T3 stage to these tumors. The prognosis between these two subcategories is not of much difference. So the second image in this slide shows a very locally advanced tumor where the space between the bladder and the rectum is completely obliterated. So the first image, the arrow is pointing to peritoneal, pelvic peritoneal reflection. So this peritoneal reflection in the second case is completely obliterated and is infiltrated by the tumor, which means it is a T4A tumor because of involvement of visceral peritoneum, parietal peritoneum. So these two are examples of T4B case. The first image is where the tumor anteriorly is infiltrating the cervix, and the second image is where the tumor on the left side is infiltrating the seminal vesicle. So these are T4B tumors. Now other than the TNM stage, we also have to comment on extramural vascular invasion or EMVI. What is EMVI? When the tumor signal is seen directly and contiguously extending into the adjacent mesorectal vessels or veins, it is called EMVI positive. If you have to see the tumor signal extending directly into the vessel with or without distending the vessel, with or without alteration in contour of the vessel. Now this is very important to note because it's an independent strong predictor of either synchronous or future metastatic disease. Now CRM is the other term that we need to be familiar with. It is it's synonymous to mesorectal fascia or circumferential resection margin. So as you can see in the first image here, when we talk about the extramural spread, we see the radial extent of tumor beyond the muscularis propria outwards. But when we talk about distance from mesorectal fascia, we want to see the distance from outer or the advancing margin of tumor till the closest point in the mesorectal fascia. So if mesorectal fat is thinner in a certain place where the tumor is, even a T3A tumor can technically involve CRM positive. But if there is a lot of mesorectal fat in that point of the tumor, even a T3C tumor need not involve the CRM. And another important point is that the CRM need not be involved just by the primary tumor. Even a EMVI in contact with the mesorectal fascia or a lymph node in contact with the mesorectal fascia is considered as CRM positivity. And any tumor within 1 millimeter from mesorectal fascia is considered as involved. 1 to 2 millimeter is considered as threatened. So we have examples of, in the first case, the yellow line is what tells us the distance from mesorectal fascia or CRM measuring so much. And in the second case, the tumor is touching the mesorectal fascia where CRM is considered involved, and this case would need a neoadjuvant treatment prior to surgery. Now, in addition to these parameters, for lower rectal cancers, it's also important to tell if the tumor is extending below the level of puborectalis. So the anorectal junction is considered as the upper border of puborectalis sling. So when tumor is extending anywhere below the upper border of puborectalis sling, we considered anal canal to be involved, and within anal canal it's important to differentiate between only internal sphincter involvement, or like in the right sided image where the tumor is bulging into the intersphincteric plane, or if the tumor is extending beyond the anal canal sphincters. So that determines the extent and nature of surgery that might be needed, whether levator ani and sphincters can be spared. Nodal staging depends on a number of tumors, number of lymph nodes, suspicious looking lymph nodes that are in the mesorectal fascia and in the regional draining nodes, which are mesorectal and internal iliac nodes. So 3 or less suspicious appearing lymph nodes are considered as N1, 4 or more is N2. Now, what do we mean by suspicious appearing lymph nodes? It's not just the size. Obviously, anything more than 9 mm is considered suspicious. But even if the nodes are less than 9 mm, if they have these features like indistinct or irregular margins, which could mean it could potentially be a tumor deposit and not necessarily extranodal spread within the lymph node. Or if we have a heterogeneous signal intensity lymph node or a very rounded lymph node, these are considered as suspicious morphology lymph nodes. And depending on the baseline short axis diameter of the lymph node, one or more of these features must be present. Now, short note on the role of diffusion weighted imaging. So diffusion weighted imaging is actually a paired set of images, DWI and ADC map. It's like a photograph and a negative. So on DWI, any cellular tumor will appear extremely bright, and on corresponding ADC map, this tumor appears dark. That is called diffusion restriction. Now that tells us that there is viable cellular tumor. It's very important to have this baseline diffusion weighted imaging, especially when patients are being considered for neoadjuvant setting. Because post-chemotherapy or post-chemo radiotherapy, if you have persistent diffusion restriction even in a small portion, that indicates that there is viable tumor. So the role of MRI in post-neoadjuvant setting, the timing of the MRI, it's important to do it at least 6 to 8 weeks after neoadjuvant treatment for the treatment to have consolidated effect on the tumor. And it's important to assess the extent of fibrosis, which appears very hypointense compared to a intermediate signal intensity tumor. Sometimes intermediate signal intensity tumors can show mucinous degeneration after treatment, and they appear very bright. And as I said, it's important in predicting viable tumor component, and diffusion weighted image plays an important role. So we restage the tumor and we ascertain a MR tumor regression grade from 1 to 5 and identify patients who can be followed up for total neoadjuvant therapy. So how do we give a MR tumor regression grade? When there is complete radiological response, which means there is no evidence of ever treated tumor. Normal restored rectal layer morphology is present, it is called grade 1. Grade 2 is good response when there is dense fibrosis or treatment response mucin, but there is no tumor signal intensity on T2 or diffusion weighted imaging. It signifies that either there is no viable tumor or minimal residual microscopic disease that cannot be picked up on MRI. Grade 3 is when this moderate response, when more than 50% of the tumor is composed of fibrosis or acellular mucin, but there is some visible viable tumor. Grade 4, mostly viable tumor, fibrosis or mucin. Grade 5 is when there is no response, that is, tumor has no change in size or appearance compared to pre-treatment MRI or has progressed. So examples of each of these tumor regression grade. The first image shows that there is a small non-circumferential tumor, and the bottom image shows the restoration of normal rectal wall morphology after treatment. Because it was a low rectal tumor, he was considered for neoadjuvant treatment. So there is no evidence of ever treated tumor. So this is TRG1. This is another low rectal tumor with T4B status, and post-treatment predominantly tumors replaced by fibrosis. There is some residual tumor intermediate signal intensity component, and so this is viable tumor TRG3. This is a mid-rectal T3B tumor. So post-treatment, most of the tumor is completely replaced by this hypointensity on T2 weighted imaging, bottom left image. But we are not really seeing any appreciable intermediate signal intensity component on the T2. However, the diffusion weighted imaging is showing that there is a small focus of residual diffusion restriction. This is not picked up on T2. This is the importance of diffusion weighted imaging, having baseline and repeat in the post-treatment MRI. So this tells us that there is viable tumor, and so this is again TRG3 and not TRG2. So there's some challenges we face regularly when assessing the post-treatment MRI. When we don't have a pre-treatment MRI, which is done according to a required protocol, it is very difficult to compare or tell whether the current imaging findings are because of post-treatment response. They were there to begin with. And especially in mucinous tumors, there is very limited role of diffusion weighted imaging. These do not typically show intense diffusion restriction. And so predicting residual viable tumor is very difficult. Also, there are MRI challenges in differentiating between acellular and cellular mucin. And CRM assessment post neoadjuvant therapy has got a very high negative predictive value, which means if we say that CRM is not involved post treatment, that we are almost always right. However, when we say that CRM is involved by tumor, the positive predictive value is not great because that may be involved by fibrosis rather than viable tumor. Nodal staging, morphologic criteria cannot be as reliably used post treatment, and so we rely on the size criteria. So in conclusion, tailored MRI with good T2 high resolution images in 3 planes and diffusion weighted imaging is extremely important in local staging and prognosticating disease, and MRI can help in deciding on neoadjuvant treatment and plan of type of surgery, and post neoadjuvant setting to assess the tumor response and feasibility of surgery, and choosing the small subset of patients for total neoadjuvant therapy. EUS and PET CT have complementary roles. Thank you.
Thank you, Dr. Tarini. I think it's very clearly seen that MRI imaging is extremely important for rectal cancers in terms of planning treatment and follow-up of these patients, and this was an extensive review of this area. Thank you very much. We next go on to another area of imaging which is equally important, and that is the PET scanning in these patients. And to talk to us on this is Dr. Sunita, the Head of Department of Nuclear Medicine at the AIG Hospitals. Dr. Sunita.
Good evening all. Thank you, sir. Today I will be discussing about the role of PET CT imaging in colorectal malignancies, its clinical impact. So my topic of the talk will be on advantages of PET CT, what are the various commonly used radiopharmaceuticals, how the patient is prepared and when to do the scan, and regarding the colorectal malignancies, whether it is useful in the diagnosis, and then the other indications in initial staging, assessment of therapeutic response, radiation therapy planning, and also in the case of recurrence assessment. So let's see it one by one. First, what are the basic advantages of PET CT? Why the patient require PET CT? The basic advantage is high sensitivity, and also it is quantitative, and especially it is useful in the case of temporal monitoring, means whenever the patient is planned for neoadjuvant chemoradiotherapy, then PET CT is quite useful whether the patient is responding to the treatment or not, which acts as a prognostic indicator. But it has its own disadvantages. First is radiation exposure. Around 12 to 15 millisieverts of radiation exposure is there, so it should be planned accordingly whether to use PET CT and at what are the basic indications, what are the advantages. Based on this only we have to plan PET CT, otherwise radiation exposure is high. Next is the commonly used radioactive material has less half-life, so an in-site or nearby cyclotron facility is required, and the spatial resolution is relatively low, but the newer generation PET CT has a spatial resolution around 0.3 mm. So let's see, these are all the various diagnostic and therapeutic radioactive material available. So our discussion will be on the diagnostic radiopharmaceuticals. The above 5 are cyclotron produced and the lower down are generator produced. Among the cyclotron produced, the most commonly used is the F18, which has a half-life of 110 minutes. This is the workhorse of nuclear medicine. 90% of the scans are done using fluorodeoxyglucose, which is labeled with F18. So we have a nearby cyclotron facility, so the medicine availability is not an issue. The other is a generator produced, which we commonly used is a gallium-68. The basic advantage is in-house preparation is can be done, so we can plan any time this one. So it is mostly useful in the case of neuroendocrine malignancies. I will discuss later on in the next few minutes. So let's see what is the workhorse, that is fluorodeoxyglucose. So it utilizes glucose metabolism and it is a marker of tumor glycolysis, and its uptake is proportional to the GLUT receptor abundance. So what is this fluorodeoxyglucose? It's just similar to the glucose, only one OH is replaced by F18. So everything is similar, but only F18 is replaced. This makes very important, because once it is taken up by the cell as similar to the glucose by the glucose receptors, it is phosphorylated, but it will not further undergo metabolism, so that it is a metabolic trapping. This is the basic mechanism of utilization of fluorodeoxyglucose, and it is similar to glucose. So we have to meticulously see how the patient is prepared, because what we inject is in micro quantities, but what the glucose available in in intravenous fluids or TPNs is in milligrams. So it acts as a competitive inhibitor. So special preparation is required. And also let's see what are the various mechanisms of fluorodeoxyglucose uptake in cancer cells. Why we prefer this FDG in cancer cells? So the basic mechanism is there is an increased glucose metabolism in cancer cells. It may be due to the increase in the glucose transporters or increased phosphorylation or reduced phosphatase. It's just a dynamic alteration among all these three which added advantage of fluorodeoxyglucose utilization in cancer cells. So as I said, patient preparation is a must. So first is fasting. At least 6 to 8 hours fasting is required so that the glucose fasting glucose levels are very low. And we have to avoid intravenous fluids like dextrose, ringer lactate, and also TPN for at least 8 hours because they act as a competitive inhibitor. And at the time of injection, the routine checking of fasting glucose is required. It should be less than 200 milligram per deciliter. And if it is more than 300, better to reschedule. If it is between 200 to 300, we utilize intravenous short-acting Act Rapid. We inject 1 hour before the time of injection, and after 1 hour we check the sugars. If the sugars are less than 200, then we inject our fluorodeoxyglucose. Next, coming on to the timing, when the patient is referred, we have to see certain preliminary investigations or history is very important in the case of functional imaging, that is FDG PET CT. So when the patient had undergone biopsy, we should be cautious. The history is very important. At least wait for 1 week or plan before the biopsy. If the patient had undergone biopsy induced inflammatory changes will be there and false positives will be there. So be cautious. History is important. Where the patient had undergone, what is the site of biopsy. Next is post surgery. After surgery, wait at least for 6 weeks to comment upon the local the recurrence or residual disease. Once the patient had undergone chemotherapy, so at least wait for 6 weeks. If we are planning PET CT for interim response assessment, the day before the next cycle, especially in the case of lymphomas, there is a very good the literature saying that interim response is important. PET CT has a role. In that case, we do the day before the next cycle. In the case of post radiotherapy, as Dr. Tarani said, we are planning neoadjuvant chemoradiotherapy in the rectum patients. In these patients, at least wait for 12 weeks or at least 8 weeks is a good enough to reduce the post radiotherapy inflammatory changes. All these are mandatory before we plan for any PET CT. History is important in nuclear medicine, that is in functional imaging. And also in nuclear medicine, all these radiopharmaceuticals have normal physiological distribution. Be cautious what are the normal physiological distribution so that we avoid false positives and false negatives. In the case of fluorodeoxyglucose, as we all know, brain utilizes glucose metabolism. So there is an intense uptake in the brain. So it has very less sensitivity to pick up brain lesions. So FDG is not routinely used to pick brain mets. Next, the route of excretion is through kidneys. So there is an intense uptake in the kidney and urinary bladder. So whenever we are planning any pelvic malignancies, we ask the patient to avoid before the scan. And also to reduce the radiation exposure to the patient, we ask them to take at least 1 to 2 liters of water and void frequently so that the radioactive material is passed through the urine and radiation exposure to the patient is less. So 2 advantages to comment on pelvic structures and also to reduce the radiation exposure. We ask them to pass frequently and also just before the scan. Next, coming on to the role of PET CT in colorectal malignancies. So let's see whether it is useful in the diagnosis or not. So as of now, it is not useful for diagnosis. Only endoscopic ultrasound and MRI are quite useful. But what is the role of PET CT is, if there is an incidental FDG uptake that is only focal, then better to evaluate by colonoscopy, because around 75 to 88% of these patients have either malignant or pre-malignant lesions. So incidental focal FDG uptake better to evaluate by colonoscopy. Next, coming on to the initial staging. In initial staging, no routine use of F18 FDG. Only the anatomical imaging like CT or MR are quite useful for initial staging. Then where comes the role of FDG? So FDG comes only as a problem solving tool, especially in the case of indeterminate liver lesions on CT, or whenever there is a preoperative evaluation of resectable metastasis, whether it is a liver or extra hepatic. If it is a resectable, then better to do PET CT because it has high sensitivity and specificity. So in initial staging where there is a literature says that better to do PET CT whenever there is an indeterminate findings on morphology, and also when intravenous contrast is contraindicated or a claustrophobia to MRI. These are the two indications for initial staging in colorectal malignancies. So but there are certain guidelines, that is ESMO guidelines for rectal cancer. They consider to do PET CT whenever there is an extremely elevated CA levels and high clinical suspicion of metastatic disease, and also as extensive extramural vascular invasion, that is whenever the EMRI is positive or CRM is involved, that is locally advanced. In these cases PET CT is quite useful. So let's see one example. A 61-year-old male who has diagnosed with an adenocarcinoma sigmoid colon. This is the maximum intensity projection image. This is the primary lesion, adjacent local lymph nodes. So this patient had a preoperative resectable liver lesion. So this patient had undergone PET CT. So the PET CT showed a lesion in segment 7, but 2 lesions are picked up in PET, that is in segment 8 and 5, which are segment 7 and 8, which are confirmed by biopsy. And there is an incidental focal uptake in sigmoid colon, which by colonoscopy on histopathology revealed as tubular adenoma with high grade dysplasia. So whenever focal FDG uptake is there, better to evaluate by colonoscopy, and whenever there are resectable metastasis, better to do PET CT so that we can avoid unnecessary surgeries, whether to downstage or upstage. PET CT is quite useful. So these are the two indications in initial staging. The next indication where PET CT is useful is assessment of therapeutic response. So as we all see that in rectal malignancies nowadays, whenever there is a locally advanced, we do see neoadjuvant chemoradiotherapy. In these cases, and also in the case of liver metastasis, whenever local therapies like transarterial the chemoembolization or TARE, these patients, whenever they had undergone these treatment, PET CT has quite good performance. It has excellent negative predictive value. And in the case of rectal cancer, to know the response assessment, if they are responding, the prognosis is good. If they are not responding, the prognosis is bad, as pathologist Dr. Anuradha explained in detail regarding the response to the therapy. This is an example of a 45-year-old male with a lower rectal malignancy, the intensely FDG with hemicircumferential wall thickening. So this patient had undergone neoadjuvant chemoradiotherapy. So after 8 weeks, so in AIG we routinely follow PET CT after 8 weeks of neoadjuvant chemoradiotherapy. So this patient had complete morphological response and also metabolic response. So the prognosis is good if the patient is responding. So another example where the upper images are the baseline images and the lower images are the response assessment. This is the maximum intensity projection image, and these are the axial fused images. So this patient had a primary with the local nodes and the liver lesions. So post chemotherapy, because these lesions, this patient has multiple liver lesions, so this patient was given only neoadjuvant chemotherapy. Post adjuvant chemotherapy, this patient responded completely by liver, but only partial response in the case of primary. So next, the other valid indication is in radiotherapy planning. So after neoadjuvant chemoradiotherapy, it has a very good performance, and also the results show that whenever patients are planned for neoadjuvant chemotherapy, better plan using the PET CT. So in our AIG, we routinely perform PET guided RT planning, and the results are good. Next is recurrence assessment. So especially useful whenever there is a rising trend of CEA post treatment, and whenever the imaging is morphological imaging is inconclusive. These two indications, PET CT is quite useful. Let's see one example. So this is our patient, a 66-year-old male who was treated for a carcinoma descending colon in 2018. So this patient has a rising trend of increasing CEA. PET CT was advised. This patient had intensely FDG with heterogeneously enhancing soft tissue mass in the pelvis, which was biopsy confirmed as a metastatic disease. So the other indication is when morphological imaging is inconclusive. So this is a 61-year-old male who had a locally advanced adenocarcinoma rectum, who was treated with surgery and adjuvant therapy with rising trend of CEA levels. After 28 months, this patient was referred for CT. CT was inconclusive. So this patient was referred for the PET CT. There was a focal FDG with lesion in segment 2, which was confirmed by MRI. This is positive lesion, and this patient also had hypodense lesion in the MR from in the baseline and also in the follow-up, which is not, there is no change in size, it's a benign lesion. So these are all the indications of routinely used FDG in our the nuclear medicine. Next, coming on to the other radiopharmaceuticals, as I said, the other is generator produced, that is gallium-68 labeled the dotatate, that is which is used in the case of neuroendocrine tumors. So what are the indications? Just like FDG, it is useful in the case of unknown primary with NET metastasis to know the site of primary, and also once the diagnosis is confirmed to know the initial staging, and also whenever the biopsy is inconclusive, then the PET guided biopsy can be done, and also in the case of biochemical recurrence. So let's see if you and this we have to be careful. What is the physiological uptake? In DOTA, the uptake is intense in pituitary gland and salivary glands, and intense uptake is seen in the spleen. So physiological distribution we have to be aware. So let's see few examples where DOTA is useful. So a 58-year-old male with a history of multiple liver lesions which are biopsy confirmed metastatic NET. This patient is referred to nuclear medicine department to know the site of primary. The site of primary is a rectal lesion. It's a polypoidal lesion in the mid rectum along the lateral wall, which was biopsy proven primary site of malignancy. And next is follow-up whenever there is any symptoms of NET or markers are raised. In these cases, PET CT is quite useful to know the site of recurrence. So this is a 37-year-old male with a treated case of carcinoma rectum. So with the symptoms, this patient had a tiny DOTA avid left internal iliac lymph node, which is biopsy proven as positive. Nowadays, most of the studies from 2018 are on the interesting topic, that is FAPI. So almost all the articles from past 2 years we are seeing on fibroblast activation proton inhibitor. Let's see what is the basic advantage. It has low background signal, that is very minimal uptake in the brain, heart and liver, and almost 28 malignancies are showing intense uptake of FAPI compared to the FDG. FDG has its fallacies, especially in the case of mucinous carcinomas, signet ring cell carcinomas, where FDG is low. So we may miss the metastatic lesions, or the primary may not be conclusive. In all these malignancies, FAPI is doing better. So FAPI contains a DOTA chelator. This can be used for a theranostic approach. That is, it's a theranostic pair. If we replace the gallium-68 with beta emitting like lutetium or alpha emitting like actinium, we can treat the patient if the patient is the metastatic. So this is the physiological distribution where there is a negligible uptake in brain, liver and also in the pelvis. So especially in the case of colorectal malignancies, that is signet ring cell mucinous malignancies, and also in the case of cholangiocarcinomas where FDG has very minimal role. In these cases, FAPI, we can try FAPI and it's showing excellent results. These are all the various malignancies which are showing intense uptake, especially colorectal malignancies, and also in the case of cholangiocarcinomas where it has very good role. So let's see one example where FAPI, that is gallium-68 FAPI, and the advantage I said, it's a the generator produced, so in-house preparation is available, and there is no need for us to depend upon the cyclotron. So it's a carcinoma colon. This is a primary staging. This is a MIP imaging. This is the primary site of colon. So this intense uptake is seen in the lung nodule, which was inconclusive in FDG PET CT, and also multiple liver lesions. So it results in the upstaging of this disease. Thank you so much.
Thank you, Dr. Sita, I think, for that extensive coverage of role of PET CT in this situation. We now come to our last topic, which I think is also becoming extremely important. In the era of personalized medicine, precision medicine becomes extremely important. We can now target our therapies in the patient based on individual patient responses. And to talk to this, we have with us Dr. Kalyan. Dr. Kalyan did his internal medicine in US and then subsequently specialized in genetic medicine at the Stanford. He runs this K&H unit and also is associated with AIG Personalized Medicine Department. He'll talk to us on molecular testing for precision medicine in colorectal cancer. Kalyan.
Thank you very much, sir, and thank you, Dr. Nageshwar garu and Dr. Jiro garu for inviting me to. Actually, the topic that we are discussing is of utmost importance given the time and given the condition. So let me briefly go in the relevance of this topic. So this is, as per WHO, the worldwide cases of cancers. And if you see colorectum, it is around 20 lakh people at this time are having colorectal cancers. This is worldwide. But if you come to India, this is Asia and India. If you can see, half of the world population in colorectal cancer are from India in 2020. And if you see, compare from the backslider now, the liver, the esophagus, the stomach, it is on rise. This is because there is some lack of awareness in terms of screening and in terms of currently available practices, be it epigenetics, be it dietary changes. All these have very significant impact. So coming to the main point, the colorectal cancer. As my learned colleague already explained, most of them are sporadic, which means you are not born with them. It happens because of epigenetic factors. And only about less than maybe 3% are truly inherited, which are present in the germline, and most of them are sporadic. So these are the genes that we check, and this been extensively discussed so far. So I will go towards what is this personalized medicine about, and how did it start, and where we are right now. So historically, the first one, when we are doing medicine, there were no targeted therapies, there were no genomics, or all we know is genetics or Mendelian. So the first medication that they found was tamoxifen. It is a targeted therapy. So it has a tremendous impact on treatment of breast cancer at the time. And in 1982, they started, okay, now we have the oncogenes develop. Oncogene is nothing but these are the genes which we identified that these are the genes which have any kind of mutation will develop into a cancer at a later stage. And going forward, extensive research has been done, and the first medication, which is targeted therapy, which is curative for cancer, came in the form of imatinib. So the lifespan of all CML patients improved tremendously. So at the time, so sequencing was very expensive business, and it was not available for a patient at the time. It was only for research. So the breakthrough technology, which is right now what we are using, is called NGS technology, next generation sequencing. It started in 2005. And since then, the sequencing became very easy, and there were all the tumors are being sequenced. And since then, a lot of research went into what is it, why people are developing cancers kind of thing, and what are the main pathways which are drivers to have this developing of cancers. So from here, multiple pathways, EGFR pathway, vestibular growth factors pathway, KRAS pathway, BRAF, all the medicines that we are targeted are started after the invent of NGS. So coming to the molecular testing for cancers. So right now, the initial path breakers are called the company called Foundation One. What they did was they gathered these tumor samples, and then they said, okay, let us do DNA sequencing. And since 2011, they've been working on extensively. They went to clinical trials. They associated with the multiple institutions, and then they did sequencing of all these tumors. And in 2017, FDA approved, okay, Foundation One, you can develop as a test for all solid tumors, where you can do sequencing and give what are the targeted treatments available. And in 2014, the same thing, Memorial Sloan Kettering Hospital they started developing a huge database. Fortunately, I'm part of developing that database back in the day. So right now, they are also having FDA approval to do multiple sequencing patterns. And right now, there are almost for colorectal cancer, this is the timeline. So the first medication which was approved was called cetuximab in 2004. It is an anti-EGFR agent, and this became really standard of care at the time. Every colorectal cancer which is stage 3 and stage 4, we're getting these medications. But in 2018, they figured out, okay, cetuximab is not working on everybody. We need to look for KRAS mutation. So if you have only wild type, which means there is no mutation in the KRAS gene, especially in chromosome 2, codon 13 and 12 and 13, then only cetuximab will work. And then there are multiple medications which started. But all these medications, they cannot be given blindly. We need to look for what is the mutation present, and why do we need to get it tested. In the last 3 years, it is almost all the medications are immunotherapies which have been approved, and they are doing a tremendous job. So the lifespan for even stage 4 colorectal cancer is improved tremendously, but still the main goal of the topic here is if you have colorectal cancer in stage 1, you can have a curative surgery. All these molecular testing and a lot of imaging will happen only in stage 3 and stage 4, or if you need chemo, or if you need adjuvant radiation therapy. But having a colorectal cancer, it can be prevented and it can be identified at an earlier stage, and you can have a curative treatment, which is surgery. And these are the 4 tests which are approved by FDA, which are available at this time for all solid tumors. The first one is Foundation 1, the second one is MSK Impact. So, if you look at the number of genes assessed, there it differs between each and every company. The reason is all these genes which we are assessing, even though there are no targeted therapies, all these genes are proven oncogenes. I will come back at the later point why testing for all these things are important. But we can identify copy number variations, gene fusions, MSI, TMB, except for PDL1, most of the testing can be done by gene sequencing. Usually we do it at a depth of 1000x so that we will not miss any areas which are of important. So these are the biomarkers that we are right now looking at colon cancer, especially KRAS, which is wild type, so that you can get cetuximab therapy, and other biomarkers as the previous speakers mentioned. All MSI markers are of utmost importance, and everybody has to be checked for this one. It can be done through PCR model, IHC model, but NGS is not inferior to those testings. And BRAF, which you can get in a target therapy, which significantly improves. But the problem here, what happens is, as Dr. Ravikant mentioned before, we do not know what is the MAF. MAF is mean allele frequency in Indian population, because we don't have that data. What we have is what is the frequency of these mutations in Caucasian populations, in African American populations, in Japanese population, in Chinese population, but we don't have anything. We are pulled into a group of South Asian population. How many Indians are there? We do not know. That is where the genome AD represents. So we need to develop this kind of a database where we will know how many of these mutations which have targeted therapy, and how common is it in Indian population. And this is NCCN recommended therapy, and I am not talking about the regular conventional chemotherapy. This is only targeted therapy. So the first thing we look for is that the patient is wild type or mutant for KRAS, and if this is mutant, then we will directly go for MSI stable, and then we either look for bevacizumab or anti-PDL depending on the testing. And for wild type, we look for left or right column. This is the NCCN guideline, and these are the pathways which are potential for targeted therapy for now in colorectal cancer. And there are medicines already available in the market for EGFR, VEGF, and some of the Notch proteins, and also other immune checkpoint mediators. So if you look at this, it is a little bit small, but the drugs in pipeline, it is enormous, especially in phase 1, 2, and 3. So table 2 indicates these are all the trials available across the globe which are developing targeted agents for EGFR. Most likely within the next 4 or 5 years, almost half of these medications are coming into market. And table 4 is anti-angiogenic agents, which is mostly EGF inhibitor. And if you count the number, there are more than 380 phase 2, phase 3 trials which are currently on trial, and most likely the success rate will be around 20 to 30% that they will hit the market. And the next one is HGF MET. Again, multiple trials are going on, and other novel agents which are mostly immunotherapies. And this is immune checkpoint modulators. So if you look at all these medications, there are more than 390 phase 2, phase 3 trials happening across the globe, which are developing targeted therapies, which are going to be either first line or second line chemotherapy options for metastatic colorectal cancers. And coming to our experience, so we did a sequencing greenhouse, and we use MSK Impact database for our analysis and algorithms. So if you look at first chart, SNV file for novel mutations. So for each cancer, each tumor, we do 380 genes at a very deep depth. And what we find is, if you look at the number of mutations we find in each cancer, there are around 21,000. But out of these 21,000, in only 8,000 are documented, which means if you look at the third graph, there is an RS number. So if there is RS number, which means it is documented that this has some significance and it is documented in the global database. Everything which is novel, we do not know what it means and how common it is in our population and what is the significance of it, we do not know. So almost we only know about 1/3 of the changes in our genome in a tissue of colon cancer that we can have an clinical report on them, but remaining things are all novel. So coming to the second paragraph, it is all copy number variants, which is either insertions or deletions, which have more significant impact. Even in this one, there are almost 353, and these both files belong to the same patient, and this patient is stage 4 colorectal cancer. And this patient has almost 353 copy number variants, including insertions and deletions, and out of which we know the function of only 113. So we only scratched the surface when it comes to molecular pathology and molecular genetics. But this is about high time that we need to start doing more sequencing of our tumor samples, and then we need to have an collaborative effort right from the medical oncologist, surgical oncologist, and pathology department, and everybody to work together to see how we can really decipher what is the tumor causing mutation, why the incidence compared to 30 years back is significantly increased, especially in Indian population. And is it that we are finding out more, or is it because we are having more cancers that need to be answered as well? And coming to GI tract, not only just colorectal cancers, we are seeing as the previous mention was saying 37-year-old with stage 4 rectal cancer, 28-year-old with stage 4 rectal cancer. This was uncommon some 30 years back. What are those epigenetic changes which are impacting this the high incidence of these colon cancers? And as we know already that most of these are sporadic. So it is about high time that we need to have molecular testing of most of these tumor cancer cells, and I think we are beyond time. So I will conclude here, and once again, thanks for the opportunity, Dr. Nageshwar garu and Dr. G.V. Rao garu, and thank you so much.
Thank you, Kalyan. I think precision medicine is going to be the next thing in treating many of our cancers, and colorectal cancers are no exception. Thank you for taking us through all this data and also the uncertainties in this area. Most important, I think we require to generate our own data because of the marked variation that we have seen from the first presentation that Ravikant gave us. So we have to develop our own data. I think this will become the cornerstone of treatment of many of these patients. As we come to the end of this session, I'd like to thank all of you for listening to this. I'm sure all of us had a very educative session. We'll continue with this series, and tomorrow we'll meet again on therapies of endoscopic therapies in patients for colorectal cancer, both the early stages and late stages. Hope to see you again tomorrow.